Hello, my name is David Bishop, and today I'm going to be speaking to you about anesthesia for the critically unwell, specifically focusing on how to do this at district hospital level, where there are significant challenges. Now, if you look at a basic anesthetic chart, you'll often notice that heart rates and blood pressures fluctuate during that anesthetic. And when you anesthetize, there's lots of things to do. You have to be focusing on these hemodynamic changes and fluids and what the surgeons are doing and all of these things that are going on. And when you've got a healthy patient, sometimes patients survive despite what we do, not because of what we do. And what I mean by that is that the patient's own physiology protects you and gives you wider margins within to work. So if you let the blood pressure drop too low, often the patient's own physiology will compensate for that. However, when we anesthetize critically ill patients, they've often lost that ability, and so the anesthetic becomes very, very important. And one of the key things, especially in district hospitals, is that you need to be able to focus on this patient and only focus on that. You shouldn't have multiple roles like resuscitating a baby or perhaps assisting with surgery or popping in and out of the room. Critically ill patients require your full attention, and they require a lot of refinements around the way that we manage them. So what I'm going to talk to you about today is firstly thinking about recognizing these patients and labeling them as sick patients, reacting to that label, refining what you do, pausing whenever you can when the patient's stable enough to think about adjusting and adapting and maybe referring the patient, and finally concentrating on the recovery period. So those are the 5 areas that I'm going to deal with today. So how do you recognize a sick patient? Now, there's obviously a lot of literature that's been put out on this. There are a lot of methods that you can use, but they do tend to have similar features, a fingerprint to how they look. And the most obvious way is to use the vital signs. Now, I don't really want to get into complex ways of identifying these patients. I think that if we just pause and look at the basic vital signs that are reflected on this monitor, so the heart rate, the blood pressure, the oxygen saturations, the respiratory rate, which on that picture is shown with the yellow line, and then perhaps looking at a temperature, and finally a level of consciousness, which are obviously not reflected there. Now that's just 6 signs, and with 6 signs I think you can identify most of the patients. In particular, respiratory rate is one that we often just look at the nursing chart and you'll see that it's often reads at 20. Actually timing the respiratory rate for 30 or seconds or 60 seconds and getting an accurate reflection of the respiratory rate. It's one of the biggest predictors of hospital outcome, a high respiratory rate. The only one that beats it off is a low GCS. So when patients start to drop their level of consciousness, that's a bigger predictor of mortality. But out of the vital signs, GCS and respiratory rate are probably the strongest predictors. But we all know that very high heart rates, very low blood pressures, low oxygen sats, all of these things are going to tell you, is this patient sick? Within the vital signs, there's a thing called the shock index, and I haven't put a slide on that there today, but basically when the heart rate starts to be higher than the systolic blood pressure, then you should be concerned, and that's basically what shock index looks at. You should look at what investigations you have, and just because a patient may be sick doesn't mean we need to do thousands of tests, but at the very least, what's the ward hemoglobin? What is the finger prick glucose? These are things you should be able to get at any setting. They're point of care tests, and they sometimes give us valuable information. And if you have the ability, trying to get an arterial or a venous blood gas often gives us additional information. So I look on that blood gas for, is there a low CO2? The low CO2 suggests a tachypneic, a high respiratory rate patient, and that's a worrying sign. And the other thing that I look at is the base excess. And just as a rule of thumb, if the base excess is worse than -6, that's when I start to think I'm going to need post-operative care in the form of ICU. That's my own number, but if it's worse than -6, I think, okay, this patient is unwell. And finally, what is the pathology that this patient has? So if the patient is coming for a relatively minor operation, you can often delay or defer. If the patient has a placenta percreta, placenta accreta spectrum, then we know that this patient is potentially going to be much more complex to deal with in theatre. So really, those are things you can do at the bedside in any district hospital. You can look at vital signs, you can get basic investigations, and you can understand the pathology you're dealing with. And at the end of all of that, say, what does my gut tell me? Is this patient sick or is the patient healthy? And so what I think we should do in every single patient to recognize these patients is document what the vital signs are, those ones that I've mentioned. Document what results you have, document the pathology, and then pause and think. And really, it's very, very helpful to label the patient, this is a sick patient, because once you do that, a whole lot of other boxes need to open in terms of what you're going to do for that patient. Healthy patients often have that reserve, sick patients don't. And because they don't have that reserve, you need to set up in a different manner. So, what I want you to do when you say this patient is sick, this patient is unwell, is you should react to that label that you've put on them. The first thing is, can I refer the patient? Can I get the patient to a higher level of care? The second question you should ask is, can I resuscitate before we go to theatre or before we transfer the patient? Both a transfer and a trip to theatre, whichever one you choose, are physiologically demanding procedures. And so patients will decompensate on a transfer, they will decompensate in theatre. So you need to optimize if you can. And can I optimize my team? Am I able to get more people or more qualified or more experienced people involved? Can I talk to someone even if they're not in the hospital? Can I phone a friend? So those three questions you should ask yourself every single time you see a sick patient. And just to deal with each one of them, can you refer the patient? So how do you approach this issue? Well, the first thing is you should think, what are we going to do, and do we have the surgical and anesthetic capacity? And if that's there, if you're able to do it, like it's a cesarean section, you should be able to handle that, then you can proceed. If you think we are out of our depth, you should look for referral, and certainly discussion about referral. The second thing is, how stable is this? Stable patients can be referred, but sometimes it's the instability itself that means you can't refer the patient. So critically hypotensive patients, patients whose airway is threatened, patients who are actively bleeding, they can't be transferred. And even though you may be out of your depth and the patient may not be appropriate for a district hospital, sometimes you're going to have to proceed because of that stability. So referring the patient is often not going to be an option to you, even though that would be ideal. And finally, what's the pathology? And again, that tells you whether you should refer or not. So for instance, a ruptured ectopic pregnancy, that patient should not really be put on an ambulance. There are very few scenarios where that patient gets referred, because the patient will continue to bleed, and part of the resuscitation is the surgery. And so a ruptured ectopic, almost always you're going to need to do that at a district hospital level. Threatened airways, the one that we often talk about is a facial burn. Often you have to intubate the patient prior to transfer. So sometimes there are things that you're going to have to just deal with at a district hospital, and that's partly what we're dealing with today. So the next question you have to ask yourself is, can I resuscitate the patient? And there's some useful things to think about when you're doing this. The first is, think, what's my time frame? And that's important because sometimes, like in the case of a ruptured ectopic pregnancy, you need to resuscitate en route to theatre. So you put up your big lines, you send the specimens for blood, and you go. And on the way, you're squeezing in fluids, you may be running adrenaline, but basically you're moving towards theatre. There are other issues when sometimes you might find, for instance, a gangrenous leg in a patient who's diabetic, who's actively in diabetic ketoacidosis. There, you might want to delay while you resuscitate, but your time frame is hours, not days, because you still have to take care of the source of the sepsis. So think about, how long do I have to do this? Think about what targets you're trying to reach. So you don't just keep resuscitating until the patient starts deteriorating. You think, I need to get this much fluid in, or I'm going to resuscitate for this much time, or I'm going to target this HB. Think about them, try and document them. It helps with the process. And finally, remember the J curve. This is actually an inverted or a reverse J curve. But if you can imagine that the patient's condition, which is shown there on the y-axis, is either good or bad, positive being higher, over time and with resuscitation, the patient will improve as you resuscitate. And then no matter how much you resuscitate, the patient will start to deteriorate if you haven't taken care of the cause. So for instance, in the example that I gave with a gangrenous leg, initially when you see these patients, they will often be dehydrated, and they will get some fluids and they'll improve, and their pulses will come down, their blood pressures will come up, their respiratory rates will come down, they may even improve their level of consciousness. But that only lasts for so long. And so what you really want to do is go to theatre at the top of that curve. The problem is you just don't know when that is. Now for something like a gangrenous leg, when we've got a team working on that patient, the number we throw around is about 6 hours. If you bring me a decompensated patient in sepsis with septic shock from a gangrenous leg, my resuscitation time frame is around 6 hours. And that's just a guide. Sometimes we go earlier, sometimes it takes longer, but that's really the time frame that I'm on. And for each condition that you have, there will be a different time frame, and you just need to think through it. A hemorrhaging patient, you can't wait. Your resuscitation time frame is minutes. You've got to get to theatre. Can you optimize your team? And it's easy here to think, I need a better surgeon or I need a better anaesthetist. But what I'm very much aware of is that when you're working in a district hospital, there aren't really, for most rural hospitals, there isn't a surgeon or an anaesthetist. There are generalists. And that's what your particular skill is that you can do everything. But there may be within your group of doctors and clinicians, there may be some who are better at anesthetics, some who are better at surgery, some who are better at pediatrics. Think, who do I need in the room? Think which nurses you need. Sometimes there are particular nurses who are good in an emergency or who are more experienced. You're going to need to call those people to the theatre if you can. So you need to have some way of mobilizing your most experienced staff when you have a very unwell patient. And that can't be every patient, but it needs to be these ones. And in particular, and this is probably the most important thing, try to reduce the task sharing. So if your system is that for every cesarean section you have 2 doctors in the room, see if you can get 3 or 4. Tell people, won't you just come until we've got stability? More hands allow one person to focus on the anesthetic, 2 doctors on the surgery, 1 on the baby. Maybe when the baby is well, that person who was doing pediatrics can then assist with the anesthetic. Try and reduce your task sharing, not as your stable system, but just for sick patients. So it's really worth thinking about that. And then when you come to theatre, you need to refine what you do. So your theatre setup, you need as much staff as you can. You may need specific equipment, and you may need particular drugs. So try and think ahead. Quite often we say have emergency drugs available, but don't draw them up. In the case of the sick patient, draw them up. In particular, your adrenaline, which I'm going to come to, draw up the adrenaline, both 1 milligram in a 10 ml amp and also an infusion that is already prepared. Because when the patient starts to decompensate, you can't then be drawing these things up. So where possible, draw up all your drugs in advance. The principle of titration is very important. So often what I will do with a drug like fentanyl is if I'm going to give fentanyl, I'll just give a small dose, 20 mics of fentanyl, and I'll just watch how the patient responds to that drug. And in a healthy patient, that will do almost nothing. In an adult, sometimes in a sick patient, you'll see them becoming drowsy on a tiny dose of fentanyl. And that tells you this patient's very, very sensitive to the anesthetic drug. So whatever drug you use, don't give the full dose that you would normally give. Give very, very small doses and titrate your anesthetic. And then watch the response to the drug that you've given. It really tells you a lot about the patient, how they respond to these doses. Remember to adapt. Your patients, as you're operating them, sometimes they're getting better, and as they get better, they'll need higher doses. Or they get sicker, more critically ill, sometimes they'll need lower doses. Sometimes they'll need almost nothing. Very, very low doses of gas, almost no drug at all. And then finally, remember your unstable recipes for anesthesia. I'm going to come to that on the next slide. But you don't just plug in a full amp of induction agent. That will cause a cardiac arrest in an unstable patient. So we've published this recipe that we put for a ruptured ectopic pregnancy, but which can really be adapted to any unstable patient. We published it, me and Simon Leroux, in the South African Journal of Family Practice, and it's widely available. It's a free download, and basically this runs through various options that you have for unstable patients. And what I want to make the point to you is that when you're doing an anesthetic, it's actually a fairly simple recipe. You induce, and the old adage, which is small amp, big amp, small amp, people are thinking about opioid, so fentanyl, big amp, induction agent, small amp, muscle relaxant. So you give those, that's how you go to sleep. You maintain with either a gas or some ketamine, and at the end you switch it off, and if you paralyze the patient, think about reversing the patient. And that's a basic anesthetic recipe. And really that applies also to an unstable patient. The only difference is that the doses become very, very small. So a healthy patient might get the full amp of an induction agent, a slightly unwell patient might get half an amp, a very unwell patient might just get a quarter of an amp. So a quarter dosing when you're putting these patients to sleep. And possibly the best way to do this when you're not sure is just use ketamine. Ketamine's probably the most forgiving in an unwell patient. 2 milligrams per kilogram induction dose. Just remember that in a patient that's peri-arrest, it's also a direct myocardial depressant, so it also can be too much. But if you're dealing with that sort of patient, you just have to do the best you can in a difficult situation. That's really something that a specialist anaesthetist would need to deal with. So ketamine to go to sleep and ketamine to keep asleep, not a bad idea. And then the second tip that I want to give is that if you can avoid muscle relaxation, just use succinylcholine to put the tube in, and after that don't paralyze again. And what that enables you to do is to run patients very light. And if they're awake, they'll move before they wake up. So you can use the patient moving as an awareness monitor. If the patient's paralyzed, then there's a very high risk of awareness under anesthesia. So I often don't paralyze again. I run them as light as I can, and if the patient wakes up, at least I'll know about it. So it's a good way of being able to run as light as possible. And then when you're in theatre and you're going to sleep, so the induction period, this is probably one of the highest risk periods. I've just put the slide up to remind you to watch vital signs and titrate. Run your fluids in, so have a good IV line, strong running IV line, and remember that that blood pressure that you see just before you induce the patient is about the highest one you're going to see for a while. So what will happen after induction is the blood pressure is going to drop. So in critically unwell patients, especially when they're on a very borderline blood pressure before you start, I recommend drawing up an adrenaline infusion before you start. And that can either be 1 milligram and 50 mils if you've got a syringe driver, or 4 milligrams and 200 mils if you've got something like an IVAC, and start that at 10 mils an hour. And that's a fairly low dose adrenaline, and I actually start that before I give the induction agent. So I'll plug that into a 3-way tap or into one of the ports of the drip. I'll run the line fast, start the adrenaline, and then I go to put the patient to sleep with that adrenaline running. And then once the patient's induced, you can titrate that if you need to, but then it's set up already, and you've already got a little bit of support for that heart that's going to take a knock when you induce the patient. Like I've said, induction, you can choose one of 3 agents, but really ketamine or etomidate are the agents you'll be choosing if you've got an unstable patient. And then maintenance, you use a volatile or you use ketamine. The point that I want to just reinforce here is that ketamine is probably your best choice, 2 milligrams per kilogram. And the volatile, you'll notice the dose we put there is 0.3 to 1 in tidal. And when I've got a very, very sick patient, the isoflurane I'm running is 0.2 to 0.3. It's really on the lower end of that. And I titrate it to blood pressure. And if I've got a non-paralyzed patient, that is enough to keep the patient asleep. So the doses we use are much lower than you might think. Remember that when you're doing these anesthetics, there will come times either when you're assessing the patient or you're about to start or intraoperative when suddenly there's a bit of stability where the patient's not unstable, the bleeding's controlled or whatever. As soon as you've got the options, take those times to pause for thought. Just say to the team, what have we forgotten? Have we remembered to talk to experts? Organize the transfer post-op? Do we have to organize a way to ventilate this patient post-op? Have we remembered to order blood? All of those things that slip through the gaps, they require pauses and team reflection. So don't ignore those pauses. When you get time to pause, it's a good time to think and say, have we remembered to give the antibiotic or whatever it is? So checklists are sometimes useful at that point. And then I just want to remind you that the recovery period is an often neglected period in district hospitals. It certainly was for me when I was working there. I was so pleased that the procedure was over. I was just trying to get the patient to the ward. It's often the last time you'll have good monitoring because the nurses will be stretched when they get to the ward. There'll be lots of patients for them. Here you've got an almost one-to-one situation, so keep them there until you have a good idea, and apply what I said in the beginning about, is this patient sick? Apply that to the patient in recovery. What are the vital signs? Heart rate, blood pressure, shock index. What's the respiratory rate? Is the patient's pain controlled? Can you do an investigation again? Can you check a post-operative hemoglobin? What's the sugar? What's the pathology, and has it been dealt with? Are the patients likely to decompensate post-operatively? Think about all of those things before you sign that patient out. And then before you sign the patient out, the second thing I like to encourage is you think in your mind, can this patient do with no reviews until morning? And most often, it's a good idea to say, I think this patient's stable enough, send them to the ward, and then to go past them an hour or two later and just eyeball them, have a look at those vital signs to reassure you that they haven't decompensated in that period post-operatively. That first 6 hours, they often will have an inflammatory response, and you'll see them decompensating in the ward, and sometimes they'll do that silently. So that's all I want to say about this. These are just principles that you can use at district hospital level. Obviously, the specific pathology will define specific responses. And just remember, throughout all of this, if you've got people you can phone them for advice. It's often a phone call will change what you do. Thank you.